Thank you very much for attending this seminar, which focuses on the role of exercise as medicine for the management of chronic disease. My name is Associate Professor Prue Cormie, and I'm a researcher from the Institute for Health and Ageing at Australian Catholic University. As an accredited exercise physiologist, my research and clinical work focuses on enhancing the lives of patients using exercise. Now, our team's work focuses primarily on understanding the role of exercise for the management of cancer. But I wanted to take this opportunity to talk more broadly about the role of exercise for the management of chronic disease, summarising the evidence of the therapeutic effects of exercise and discussing the implementation of exercise as a medicine. Chronic disease is the leading cause of illness in Australia and worldwide. The World Health Organization describes the scale of the problem as a pandemic of chronic disease. And this is because of the rapidly increasing incidence and prevalence of diseases such as cancer, cardiovascular disease, diabetes, and mental illness. Now, data from the National Health Survey indicate that 1 in 3 Australians have at least one chronic disease, which is not surprising given the incidence rates highlighted here. Now, this leads to a large proportion of the population being burdened by chronic disease, over 7 million people. Now, the growing prevalence of chronic disease means that these conditions now cause the vast majority of burden of disease in Australia, 85% of it. The largest contributors to the total burden were cancer, cardiovascular disease, musculoskeletal disorders, and mental illnesses, each contributing about 15% of the burden. Now, a significant proportion of the burden is caused by premature death. And in fact, 90% of all deaths in Australia are caused by chronic diseases. Chronic disease is also the leading cause of death worldwide, claiming over 30 million lives every year. However, deaths alone don't capture the impact of chronic disease, as a larger fraction of the burden is now caused by ill health. Now, the degree of impairment associated with chronic disease means that these patients are alive, but not really living. About a quarter of years lived are spent with functional impairment, activity limitation, and restricted participation in major life areas. This equates to approximately 18 to 20 years of our lives spent with compromised well-being. Now, chronic disease is also responsible for significant economic burden. The direct healthcare costs for cardiovascular disease, mental disorders, and musculoskeletal conditions was estimated at $20 billion in 2009, which is equivalent to 28% of the allocated health expenditure. Now, aside from the fact that these values don't account for expensive conditions such as cancer and diabetes, the conservative estimate because they don't account for non-health sector costs such as residential care. And not only is the cost large, but it is increasing. The ratio of health expenditure to gross domestic product has risen severely over the last 25 years. And the figure of 9.5% is certain to increase under the weight of the ageing population, increasing incidence and prevalence of chronic disease. So because of its personal, social, and economic impact, tackling chronic disease is the biggest health challenge that Australia faces. There's an urgent need for more efficient and effective ways to prevent, manage, and treat chronic disease. And the scale of the problem commands a transformative approach to addressing it. Now, one element that holds great promise to contribute to the solution is exercise, as decades of clinical research has established the therapeutic effects of exercise on chronic disease. Now, in addition to these data, a wealth of epidemiological evidence suggests that exercise is also a powerful prophylactic measure. Regular exercise has been associated with significant reductions in the relative risk of developing numerous chronic conditions, including heart disease, hypertension, diabetes, stroke, some cancers, and also Alzheimer's disease. Robust cohort studies have also demonstrated that people who maintain superior fitness levels and engage in regular physical activity have a lower relative risk of all-cause mortality. And as you can see here, the magnitude of the protective effect against premature death is quite remarkable, ranging between 25 to 75% according to fitness and activity levels. But what I want to focus on today is the impact of exercise as an intervention for the management of chronic disease, and specifically the impact of exercise on patients who suffer from conditions that contribute the largest burden of disease in Australia. So let's start with cancer. A growing body of randomised control trials has established the efficacy of exercise in the management of numerous cancer types. Exercise has been consistently shown to counteract the deconditioning caused by cancer and its treatment, and to improve functional capacity. Exercise helps alleviate fatigue, and in doing so is one of the only interventions to address what is probably the most common and debilitating side effect experienced by patients. Exercise can also help alleviate psychological distress, as well as the severity of common side effects such as pain and detrimental changes to body composition. Now, while not yet confirmed by randomised control trials, data from a growing number of observational studies demonstrate that higher levels of post-diagnosis exercise are associated with a lower risk of recurrence and improved survival among multiple cancer groups, predominantly breast, prostate and colorectal cancer. Now, collectively, this evidence compelled the American Cancer Society to advise all people with cancer to avoid inactivity and engage in regular exercise both during and after treatment. Now, similarly, an extensive volume of research supports the National Heart Foundation's strong recommendation for people with cardiovascular disease to exercise regularly. These recommendations specifically state that survivors of a recent cardiovascular event should participate in supervised exercise rehabilitation and progress over time to the recommended exercise dose. Direct benefits of exercise for cardiovascular disease have been well established. Exercise helps prevent further narrowing of the blood vessels, helps prevent blood clotting, helps deliver blood to the heart, and helps the heart maintain a normal rhythm. Now, these effects contribute to a low risk of cardiovascular mortality. And additionally, habitual exercise increases functional capacity and reduces the severity of symptoms experienced by patients with cardiovascular disease. There is also compelling evidence of the efficacy of exercise in the management of type 2 diabetes. Regular exercise improves glycemic control and insulin sensitivity in patients. It positively affects body compositions, reduces dyslipidemia, and improves blood pressure. And the magnitude of effect on these factors often mean that patients who exercise regularly can reduce their reliance on diabetes medications. Now, over 8 million pharmaceutical scripts are claimed for these medications annually. So exercise has the potential to contribute significant savings to the cost of diabetes management. And in addition to these effects, 60% of people with diabetes also have cardiovascular disease. So clearly the potential impact of exercise in these patients is significant. And this is highlighted by numerous organisations, including the American Diabetes Association, recommending exercise as a key element in the management of type 2 diabetes. Now, exercise also plays an important role in the management of osteoporosis. It's recognised as one of the most effective strategies to reduce bone loss and improve or maintain bone strength. The incidence of hip fractures have been observed to be as much as 45% lower in people who exercise regularly. And regular exercise is also associated with a reduced risk of falls, which is brought about through improvements in strength and balance. Around 90% of hip fractures are estimated to occur as a result of a fall, so preventing falls is clearly an important part of the management of osteoporosis. So again, the strength of evidence prompted Osteoporosis Australia not only to recommend exercise to patients with osteoporosis, but to identify exercise as an important part of the rehabilitation after a fracture has occurred. Now, the pain, weakness and stiffness experienced by patients with arthritis often limits them from participating in exercise. But the American College of Rheumatology recommends that all patients with symptomatic arthritis be enrolled in an exercise program. And that's because exercise can be very effective for these patients. Although somewhat counterintuitive, exercise actually reduces joint pain, and the magnitude of pain relief is similar to that attained through pain medication. Exercise also effectively counteracts the weakness and stiffness that leads to functional impairments in patients with arthritis, prompting improvements in mobility and flexibility. Numerous systematic reviews and meta-analyses have confirmed exercise as an effective therapy for the management of clinical depression. And in fact, the antidepressant effect of exercise may be as effective as pharmaceutical therapies. Exercise counteracts fatigue and helps mitigate medication side effects such as weight gain and libido. And there is also evidence to suggest that regular exercise is associated with a reduced risk of future depressive episodes. Not surprisingly, exercise is now recognised as a treatment option in the clinical practice guidelines for the management of depression in Australia, the UK and America. And as a very brief aside, I also wanted to point out the evidence regarding the role of exercise in counteracting the negative health effects of obesity. Now, this is especially relevant considering that over 60% of Australians are now overweight or obese, and this number isn't getting any lower. The data displayed here are from a longitudinal study in older adults who are objectively obsessed for fitness and body composition. What they show is that obese people who are physically fit have a significantly lower risk of dying than normal weight people who are unfit. So these data, which are not isolated findings and have been replicated many times throughout the literature, suggest that regular exercise offsets the negative health effects of obesity. The scientific evidence clearly supports the beneficial effects of exercise in the management of these common chronic diseases, each of which have a distinctive etiology. So, how is this possible? Why is exercise effective? Exercise has an impact on all of these diseases because it improves the structure and function of most of the body systems simultaneously. And in fact, there's no single medication or treatment that can influence as many organ systems in a positive manner as exercise can. It improves cardiac output and endothelial function, enhances the efficacy and the efficiency of the respiratory system. It builds muscle and strengthens bones. It favourably modulates the production of hormones, prompts neural adaptations, and enhances immunity. But how does exercise do this? Well, it's a potent regulator of a range of physiological processes in most tissues. Specifically, exercise reduces the systemic inflammation and oxidative damage. It regulates cellular metabolism in muscle, liver and adipose tissue, as well as a range of other tissues. It also regulates levels of androgens and estrogens. Exercise prompts epigenetic modifications that are concordant with health-enhancing phenotypic adaptations. And it modulates neurotransmitters which shape everyday functions. Now, undoubtedly, if the effects of exercise could be encapsulated in a pill, it would be the most widely prescribed medication in the world. Now, the pleiotropic effects of exercise mean that even if this pill had just a fraction of the positive health benefits regular exercise provides, it would be viewed as a miracle drug. And it's likely that not prescribing such a drug would be considered as unethical and negligent. But despite the demonstrated clinical benefit of exercise, it remains underutilised as a therapy in the medical community. Now, data from America indicates that less than a third of adults receive advice about exercise from a physician or other health professional. And my guess is that this advice wouldn't have been given with much emphasis in the majority of cases. So, how can we realise the therapeutic effects of exercise? It is clear that exercise is a medicine every patient with chronic disease needs to take. So a standard of care model is necessary in order to implement exercise medicine into the chronic disease management paradigm. Now, this starts with viewing exercise as a vital sign. So like other vital signs of health, patients should be asked about exercise at every appointment. Now, this monitoring is as simple as asking, how much exercise do you do? Now, not only does this send a strong message that exercise is an essential component of treatment, but allows for doctors to inform patients of the therapeutic effects of exercise specifically for the management of their disease. Now, in much the same way that a patient leaves their doctor's office with a prescription for a medication and an understanding of why taking that medicine is important, patients should have an understanding of the impact of exercise on their disease and a prescription for exercise medicine. Now, an actual prescription is essential in conveying exercise as a medicine and helping convince patients to take it as directed. Now, this prescription could and should come from the patient's general practitioner and their specialist, as well as being endorsed by other members of the healthcare team. So, what specifically should this prescription involve? Evidence-based guidelines stipulate that patients need to perform a combination of aerobic and resistance exercise regularly in order to realise the therapeutic effects. And this involves performing at least 150 minutes of moderate intensity aerobic exercise weekly, which is equivalent to a 30-minute brisk walk on 5 days a week. Now, this should be performed in combination with 2 to 3 resistance exercise sessions, which involve lifting weights at a moderate intensity using the major muscle groups throughout the body. Now, specific exercises involved with achieving this prescription need to be individually tailored and progressed to ensure safety and efficacy in chronic disease patients. Now, additionally, it's important for the prescription to involve targeted exercises that are relevant to combating the specific issues associated with the patient's disease. This allows for the medicine to be personalised based on the patient's health status. So, for example, we utilise impact exercises such as jumping and hopping to stimulate bone remodelling in order to counteract the accelerated bone loss associated with the treatment of prostate cancer using androgen deprivation therapy. Now, as you can imagine, these specialised exercises aren't for everyone, but they do provide a potent therapy directed at addressing a specific condition experienced by these patients. Now, clearly, this is a sophisticated type of exercise medicine, which requires specialised expertise to prescribe appropriately. As such, referral to the appropriate health professional is essential to ensure patients receive a safe and effective medicine, and that person is an exercise physiologist. Now, exercise physiologists, or EPs, specialise in the delivery of exercise for the management of chronic conditions and to enhance well-being in clinical settings. Now, EPs are also trained to facilitate long-term behaviour modification and help patients overcome barriers to carrying out the exercise prescription. Exercise physiologists differ from physiotherapists who instead specialise in the rehabilitation of function following acute issues such as injuries and operations. Now, currently, there are over 3,000 accredited exercise physiologists practising throughout Australia, who can be located using an online directory of our accrediting body, Exercise and Sport Science Australia. When exercise is prescribed and monitored by an appropriately qualified exercise physiologist, it's a very safe medicine. While the musculoskeletal soreness and injuries do occur, the severity of these issues are generally minor. And importantly, the incidence of serious adverse events, such as heart attacks, is very low, with less than one complication observed in every 10,000 maximal exercise stress tests. And it's important to note that that's during maximal exercise and not the moderate intensity exercise routinely prescribed. However, there is the potential for an unqualified individual to cause harm to a patient with chronic disease, highlighting the importance of referral to an accredited exercise physiologist for these patients. So, what about compliance? Can we actually get patients to adhere to the exercise medicine prescription? Data from our work indicates that patients with chronic diseases can and do adhere. We maintain an average attendance rate of at least 80% to a 3-day-a-week clinic-based program. And the discontinuation rate is low, with approximately 10% of patients ceasing therapy within the first 6 months. Now, compliance with unsupervised exercise is certainly lower than these rates, but the 3-day-a-week clinic-based program provides patients with 80% of the prescribed exercise dosage. Now, these rates are impressive when compared to compliance rates with prescription medications for hypertension, diabetes, and depression. Many patients experience difficulty following pharmaceutical treatment recommendations, with adherence rates of between 50 to 80% and discontinuation rates in excess of 40% within the year of prescription. Now, obviously, this level of compliance comes at an economic cost. So just how expensive is exercise medicine? Well, the medical benefits schedule reports the rate of an individual consult with an exercise physiologist to range between $60 to $80. Now, Medicare subsidies are available for a limited number of EP consults, such that the out-of-pocket expense for patients is between $9 and $12. Attendance at clinic-based group exercise sessions costs between $10 and $20, and patients are able to utilise rebates from a growing number of private health insurers. Now, while much more research needs to investigate the cost-effectiveness of exercise medicine, the evidence to date suggests that the healthcare cost savings engendered by regular exercise offsets the expenses involved with meeting the exercise prescription. For example, it would cost approximately $2,500 per annum to participate in a 3-day-a-week clinic-based exercise program. And the reduction in annual healthcare costs resulting from that program was estimated at $2,200 12 years ago. Now, an important consideration to keep in mind is that investing in exercise medicine leads to significant benefits beyond improving the health of patients. Appropriate exercise significantly improves quality of life and can enhance social functioning, as well as having the potential to act as a stimulus for other health-enhancing behaviours such as healthy eating. Now, notably, a third of adults have multiple chronic diseases, which are treated with a range of different medications under the single disease framework common throughout the healthcare system. Exercise medicine represents a healthcare bargain in that it's a single cost which results in therapeutic effects against multiple diseases. So, would the systematic prescription of exercise have an impact on chronic disease management? Well, the majority of Australians don't perform enough aerobic exercise to realise significant health benefits. The prevalence of inactivity increases with age, and it's likely that a considerable majority of patients with chronic disease aren't exercising regularly. Now, when considering participation in resistance exercise in addition to aerobic exercise, which is in line with international guidelines, it's estimated that between 80 to 90% of Australians are not performing enough exercise to realise significant health benefits. So the implementation of exercise as medicine has the potential to influence the health of the majority of patients with chronic disease. But is it possible to change exercise behaviour in these patients? there seems to be a widespread belief that we can't. However, this is a relatively young and underfunded field of research, and there's growing evidence that effective intervention can prompt changes in exercise behaviour. Doctors are able to convince their patients to do incredible things. If patients can be convinced to undergo chemotherapy or major surgery, why shouldn't we be able to convince them to exercise? Education and training of doctors in effective exercise counselling, supplemented by enhanced behavioural techniques implemented by exercise physiologists, would surely have an impact. Strategies that target the patient directly and tap into rapid advances made in technologies for activity monitoring and mobile health would also play a role, as well as approaches which provide infrastructure and resources to support exercise within the community, such as walking trails and outdoor exercise equipment. Now, just think of the funding and resources dedicated to changing smoking and sun exposure behaviours and the impact these strategies have had. These examples provide a precedent for successfully changing unhealthy behaviours. The effective implementation of exercise medicine requires clinicians to monitor exercise levels, prescribe exercise, and refer to exercise physiologists. Now, while exercise is certainly not a panacea, an extensive amount of evidence clearly demonstrates the efficacy of using exercise as an adjunct therapy in chronic disease patients. The strength of this evidence justifies the inclusion of exercise medicine as a standard component of the chronic disease management paradigm. By viewing exercise as a medicine, we can realise its therapeutic effects. And put simply, exercise medicine is an effective and efficient way to help manage chronic diseases.